we will start the program. But today we are going to have a very important topic as well as a very learned professor is talking on a very important subject. Now, all of us know that collagen vascular disease is part of dermatological treatment scenario, but the problem nowadays is most of the collagen vascular disease is shifted to rheumatologists. But rheumatologists themselves treat almost all the collagen vascular disease, whether it is having a cutaneous manifestations or not. But in certain occasions, I feel that rheumatologists may have some help from the dermatologist side. So it is always better to have the dermatological interpretation of the collagen vascular disease and its lab investigations and its interpretation. Because many a time you may see the ANA is positive. What does it mean? Whether is it a normal phenomenon? It is said that around 5% of the individuals have an ANA profile. So ANA positivity. So this ANA positivity, how can we translate into the clinical scenario? That is very important. For that, it is always better to look at the dermatological manifestations. So a comprehensive knowledge of the lab procedures and its interpretations are very important. So also the dermatological manifestations of the collagen vascular disease. Last week we had a good discussion on the clinical manifestations. Today we are going to have a very good and very excellent orator to help you to understand the lab investigations and its interpretations. I will be superfluous to introduce you to Dr. Prabhakar Sangolli. Prabhakar Sangolli is a well-established clinician, well-established teacher, and well-established orator. So we are, just hear from him. And if you have any doubts, you can send the doubts through chat box, and he will clarify the doubts, and so that you will acquire a better understanding of the lab investigations and its interpretation. Over to Dr. Sangolli.
Shall I share my presentation?
Yes, doctor. Yes.
Namaste. Good afternoon. I apologize for delaying my presentation because I had one more official engagement. Sorry for that again. I apologize. So currently the collagen vascular diseases are termed as autoimmune connective tissue diseases. Now one more word is also there. Systemic autoimmune rheumatic diseases, SARD. These are the new terminologies which have been employed. So why lab testing autoimmune connective tissue diseases? Needed for establishing the diagnosis, assessing the disease activity, organ damage, and progression of the disease. There is no substitute for detailed history taking and thorough clinical examination. Please, postgraduates, make a note of it. That is the most important thing. Abnormal investigation results alone should not be an indication for treatment. One more very important take-home point. Examine the patient properly, assess the patient, come to a good clinical diagnosis, and only the investigations will supplement your clinical acumen. So I'll be briefly touching upon various serological tests in autoimmune connective tissue diseases, their applications and interpretation in individual autoimmune connective tissue disease, and summary. So we have it is classified, autoimmune connective tissue are classified as non-ANA, that is rheumatoid arthritis, and ANA-based SLE, systemic sclerosis, so Sjogren's syndrome, dermatomyositis, mixed connective tissue disease, undifferentiated connective tissues, and overlap syndrome. So basically, we focus on serum and other tissue fluid. Others are imaging and histological studies. So most important, before you embark upon serological test, one should look for anemia, leukopenia, thrombocytopenia, direct Coombs test, urine examination for proteins, RBC sediments, LFT for autoimmune hepatitis, low albumin for glomerulonephritis or inflammatory bowel disease, and APLA testing for coagulation profile, CPK, AST, ALT for the dermatomyositis, polymyositis, and inclusion body myositis. ESR monitor the disease activity, and CRP very important for infection and inflammation. Ferritin helps in establishing sepsis, inflammation, and malignancy. These tests are more important because that indicates the basic disease of the patient and end organ damage. That's where we step in. So coming to first, rheumatoid factor. This is all placed on the principle of agglutination of latex particle coated with human IgG with serum containing IgM antibodies against FC portion of the IgG. They are available as commercial source as a kit. Doesn't need any expensive equipment. Higher titer positivity is suggestive of rheumatoid arthritis and primary Sjogren's syndrome and polyarticular type of juvenile chronic arthritis known as JCA. And rheumatoid factor is also positive in SLE and systemic sclerosis. Rheumatoid factor doesn't rule out rheumatoid arthritis because 20 to 30% of the patients is persistently seronegative. Please make note of it. It's mostly negative in JCA, that is juvenile chronic arthritis. Negative in patients with seronegative spondyloarthropathies like psoriatic arthritis, ankylosing spondylitis, Reiter syndrome, and bowel disease-associated arthritis, etc. So certain diseases like infective endocarditis, tuberculosis, leprosy can give rise to false positive rheumatoid factor. A more sensitive assay for rheumatoid factor is ELISA. The results can be expressed in quantitative terms as well as 3 isotypes of rheumatoid factor are there, namely IgM, IgG, and IgA. The level of isotype of rheumatoid factor could be helpful as a prognostic parameter in assessing joint damage. Next, coming to most important, anti-nuclear antibody. It is done by immunofluorescent testing using rat tissue like liver, kidney, or stomach, or cell lines like Hep2 cells. Antibody to nuclear antigens are allowed to react with animal nucleus, and anti-human IgG conjugated with fluorescent compound and observed protein probes immunoglobulins by a fluorescent microscope. We need a fluorescent microscope. This is also a quantitative test, and the results are expressed in titer of serial dilutions. Another very important test is ELISA, which is often promoted as a major sensitivity than classical immunofluorescence assay. It is 90% sensitive and more than 90% positive in SLE patients. So ANA negative patients are seen in SLE who are on long-term steroid treatment or with chronic renal failure. They can be ANA negative. However, a negative test with clinical diagnosis of SLE needs reassessment of the patient. ANA positive in primary Sjogren's syndrome, systemic sclerosis, polymyositis, and small set of rheumatoid arthritis with JCA. It is uniformly negative in ANCA-associated vasculitis. So coming to interpretation of ANA results, high titer 1 in 160 is always positive. It is referred to a rheumatologist if there are multiple organ involvement. Low titer, that is 1:40 to 1:80, they are present in 30% of healthy individuals. So if a clinical suspicion of SLE still exists, proceed with double-stranded DNA. In asymptomatic individuals with low titer positive ANA, clinical monitoring is very, very important to look for incomplete connective tissue disease. So what are the immunofluorescent patterns? We have homogeneous, speckled, centromere, nuclear, and peripheral. So homogeneous pattern, that is uniform nuclear staining. It's in double-stranded DNA and antihistone antibodies. It is specific in SLE, drug-induced LE. The skin is malar rash, bullous SLE. They correlate with the activity. High titer also exists with peripheral rim variant. So homogeneous pattern indicates double stranded DNA, low C3, C4 levels. One dermatological tip is the patients will have photosensitivity with homogeneous pattern. So do not repeat ANA testing because it's not for monitoring. It's only for diagnosis. Clinical correlation is essential. And some specific antibodies like Jo1, ribosomal, Rho and La may be present in ANA negative by indirect IAF. When multiple ANA patterns like homogeneous, speckled, other patterns are seen, usually SLA is seen with mixed connective tissue disease. And one very interesting, in homogeneous pattern, they have an 8-fold increase of developing cancer. Next, coming to speckled pattern. There is fine or coarse granules. The targets are extractable nuclear antigens, which are Smith antigen, ribonucleoprotein, Rho SSA, and La SSB. There are again subtypes like dense, fine, and coarse. So usually speckled pattern patients will present with subacute LE or discoid lupus. They are specific and they fulfill extractable nuclear panel. High titer if RNP is dominant, that is seen in mixed connective tissue disease. Next, coming to anti-centromere antibody. Discrete speckles are seen, especially seen in limited cutaneous systemic sclerosis and CREST syndrome. And it can be confirmed by ELISA, and it's also be seen in primary biliary cholangitis. If the patient presents with Raynaud's phenomena with positive centromere, think of early limited cutaneous systemic sclerosis. Next, coming to peripheral. That is very characteristic of double-stranded DNA, and it's highly specific for SLE nephritis. And test is double-stranded DNA 90% positive. Coming to nuclear pattern, that is seen in UNP3. It is specific in diffuse systemic sclerosis, and usually it can be associated with polymyositis, systemic scleroderma overlap. Why you should know about nuclear? Because the patients with nuclear are prone for hypertensive renal crisis as well as interstitial lung disease. So to summarize, diffuse is seen in SLE, speckled is seen in MCTD, nuclear is seen in inflammatory myositis, rim pattern is very characteristic of systemic lupus erythematosus. So coming to incidence of ANA positivity, 99% in SLE, 100% in drug-induced lupus, systemic sclerosis 97, 93 in MCTD, inflammatory myositis 73, Sjogren syndrome 96%. Next, coming to double-stranded DNA. It is highly specific for SLE and it correlates with renal activity. So it can be used for monitoring and optimizing the immunosuppressive treatment. FAIR assay is one of the best sensitive tests for double-stranded DNA, and it can be also seen in chronic active hepatitis. So false positive are seen in HIV, Epstein-Barr infection, human parvovirus B19, pneumococcus, and if the patient is on TNF-alpha, false positive double-stranded DNA can be seen. Next, coming to extractable nuclear antigens, they are Smith, Rho, La, ribonucleoprotein, and SCL70. Anti-Smith, they are pathognomonic SLE, but unfortunately they are seen in only 20 to 30% of SLE patients. Patients can present with DLE. SCLE is less common. It also indicates integral CNS and lupus subsets. Confirms SLE if there is a clinical findings with positive ANA. Anti-Rho and anti-La antibodies. Anti-Rho and antibodies are seen in subacute LE in 70%. And patients present with annular polycyclic types. Anti-La is seen in can co-occur with anti-Rho antibodies. Fortunately, it's good for milder disease. If the patient has got anti-La antibodies, think of Sika syndrome and congenital heart block risk in pregnancy. The tests are Western blot and ELISA. Next, other are patients with anti-SRP have a distinct inflammatory myositis. Anti-Jo1 is seen in inflammatory myopathies. Anti-PN12, anti-EG, anti-OJ, anti-PL7, and anti-KS are reportedly more common in polymyositis than dermatomyositis. And anti-MI2 is specific for dermatomyositis. Anti-PMSCL is autoantibody for nucleolar, which I mentioned. This is seen with polymyositis scleroderma overlap. Anti-cardiolipin antibodies, they are seen in SLE. It indicates fetal loss, venous arterial thrombosis, and thrombocytopenia. And patients should be put on anticoagulants. C3, C4 are also very important in SLE. They correlate with disease activity. Elevation of C3 is seen in infections. Low C4 is seen in disease activity, like in vasculitis. CRP is one of the acute phase proteins that is seen in rheumatoid arthritis, juvenile chronic arthritis, and spondyloarthropathies. So in SLE, CRP is normal, ESR is raised. If the CRP is also raised, look for infections. Coming to disease-wise, rheumatoid arthritis, we have ulnar deviation, swan neck deformity, Boytoner deformity. These are the cutaneous findings. And 30% of them, they present to dermatology department with rheumatoid nodules and superficial necrotizing granulomas, mostly seen over bony prominences. As I mentioned, serology, rheumatoid factor in 60 to 80%, low positivity seen in SLE, MCTD, and SSC. And one highly specific antibody is anti-cyclic citrullinate peptide, anti-CCP, is very highly specific for rheumatoid arthritis. So if there is a positive array of rheumatoid factor, look for ESR, CRP, ACC, and the diagnosis is confirmed. If there is negative, think of seronegative rheumatoid arthritis or early rheumatoid arthritis and assess for ESR and CRP. Next, coming to SLE, systemic lupus erythematosus. The main complications are lupus nephritis, cardiomyopathy, CNS, lupus. Whenever a patient with clinical features and 1 in 118 Hep2 cells, think of SLE. Double-stranded DNA indicates renal involvement. And anti-Smith is highly specific for SLE. And if the patient has got anti-UNRNP with Smith antigen antibodies, think of neuropsychiatric SLE. Thrombocytopenia, miscarriage, think of APLA, antiphospholipid syndrome. So they can be anticoagulant antibodies, lupus anticoagulant, anticardiolipin antibodies, or beta-2 glycoprotein are seen in antiphospholipid syndrome in SLE. So presence of lupus anticoagulant offers better correlation than anticardiolipin or for both SLE thrombosis and pregnancy-related morbidities. So anti-Rho and anti-Ra is also present in SLE and especially neonatal lupus syndrome with congenital heart block. So when you're neonatal, think of anti-Rho and anti-La. So anti-chromatin are seen in SLE, Sjogren's syndrome, and APLA. Anti-UNRP is seen in 15 to 40% of SLE patients. Think of mixed connective tissue diseases. Anti-histone antibodies are seen in 70% of the patients. So this is a very important diagnostic criteria, which includes presence of ANA first should be the first, followed by constitutional symptoms like fever, leukopenia, thrombocytopenia, autoimmune hemolysis, delirium, psychosis, seizure, scarring alopecia, lupus hair, oral ulcers, acute LE, subacute LE, look for serositis, joint involvement, renal. This is the very important assessment confirmed by immunological like ANA, APLA, complement levels, and SSC specific like dsDNA, Smith antigens. This is for classification of diagnostic criteria. So as I mentioned, DNA specificity 70, histone 60, chromatin antibodies is 85, Smith is only 25%, UNRP 30, Rho 40, and La SSB 15. So this is a clinical criteria and immunological criteria, which I already mentioned. Next, coming to systemic sclerosis or systemic scleroderma, we have two types, limited and diffuse. Limited variant is CREST syndrome. So anti-SCL70, that is anti-topoisomerase 1, anti-Centromere, anti-RNAP antibodies, they're very characteristic of systemic sclerosis. SCL70 seen in 25 to 30% only, indicates interstitial lung disease. Anti-Centromere, CREST syndrome, anti-PMSL, mixed connective tissue disease, and Raynaud's phenomena with antibodies indicates progression to systemic scleroderma. Others are UNRNP, anti-Cu, anti-Rho, and rheumatoid factor also seen in systemic sclerosis. This is the diagnostic criteria of systemic scleroderma, that is 2013 EULAR criteria. Next, coming to Sjogren syndrome, that targets exocrine glands. It can be associated with SLE, rheumatoid arthritis, and autoimmune thyroiditis. The diagnosis of primary biliary cirrhosis is also seen in patients with Sjogren syndrome. So it is caused by lymphocyte invasion of the one or more target organs, or it can also cause vasculitis. And other autoimmune diseases are non-Hodgkin's and sometimes even Hodgkin, but NHL is more common. So serology in Sjogren syndrome is autoantibodies to systemic scleroderma, and Rho SSA is extraglandular manifestation, anti-Rho and anti-Rho 52. They are seen in anti-synthetase syndrome. Combined Rho 52 and Rho 60, they are prone for non-Hodgkin lymphoma. So Sjogren syndrome, rheumatoid factor also can be present. It indicates renal disease. And IgM-RF is more closely associated with immunological phenomena. So Sjogren syndrome, we have inclusion criteria. That is dry eyes. They have to have sandal gravel in the eyes. They use tear substitutes. They have a dry mouth. They have to use drink liquids. They are all indicative of Sjogren syndrome. So exclusion criteria, you should rule out HIV, head and neck cancer, active hepatitis, sarcoidosis, amyloidosis, GVHD, and IG4 related disease known as IgG4-RD. So these are the inclusion criteria: labial or salivary gland, anti-SSA, ocular syndromes, and unstimulated saliva flow rate is less. So that these are the inclusion criteria for Sjogren syndrome. Next, coming to mixed connective tissue disease. That is first described by Sharp in 1979. It's a prototype of an overlap syndrome. Immunofluorescence as a characteristic is UNRNP. It presents with three conditions: pulmonary arterial hypertension, aseptic meningitis, and trigeminal neuropathy. So these are the criteria. They should have at least one common manifestation of SLE or scleroderma, one immunological manifestation, and one overlapping manifestation should be there for diagnosis of mixed connective tissue disease. So at least look for SLE features, scleroderma features, and polymyositis or dermatomyositis features. Next, coming to undifferentiated connective tissue disease, is a clinical entity defined as serological and clinical manifestation of systemic autoimmune disease, however, not fulfilling any criteria defined connective tissue disease. It's a disease of exclusion, common in 32 to 40 years of women, and Rho SSA and UNRP are the commonest antibodies seen in undifferentiated connective tissue disease. The clinical features are suggestive of the defined connective tissue, but not meeting the criteria. Positive serological on 2 separate occasions, including positive ANA, and the duration of symptoms should be at least 3 years. So investigations on UCTD are CBC, ESR, CRP, urine analysis, ANA profile, serum creatinine, and vitamin D. Next, coming to last condition, dermatomyositis is known as an idiopathic immune-mediated disease presenting with muscle weakness and skin rash. So we have anti-MI2, classical DME, less interleukin, it has got a very good prognosis. Anti-MDA5, it is seen in interstitial lung disease and clinically amyopathic dermatomyositis. It is anti-melanoma differentiation associated gene. Then you have anti-nuclear matrix protein, that's NXP2. It indicates muscle involvement, dysphagia, calcinosis. Anti-NXP2 produce different tissue depending upon the age of the patient. Then we have anti-transcription intermediary factor 1 gamma, that is TIF1Y associated with malignancies. So before doing serology, we have to look for cutaneous lesions like Gottron papules, heliotrope. We have to do CPK, LDH, aldose, and we have to look for myositis specific, MI2, MDA5, TIF1, NXP2, which I mentioned, MRI for site of biopsy, EMG, skin biopsy, KRT19, interferon alpha and beta for MDA5, and CKCL for 1110. So risk factor for ILD is poor prognosis for DM includes anti-NDA5, elevated CRP-ESR, late onset DM, and clinical symptoms such as fever that indicates a poor prognosis with interstitial lung disease. So inflammatory myositis, idiopathic myositis is a subset. It includes dermatomyositis, overlap myositis, polymyositis, immune-mediated necrotic myositis, inclusion body myositis, etc. And it can be associated with DM and PM in the EULAR classification. So we have myositis-associated antibodies or myositis-specific antibodies. Myositis-specific, I mentioned those 5. Then we have ASM modified activating enzyme, anti-MI2 and anti-MDA5. So anti-synthetase syndrome associated with anti-tRNA synthetase. Anti-JON indicates disease severity. Anti-PL7 correlated lung disease. Anti-MDA also seen in anti-synthetase syndrome. And CN1A is seen in 33% of inclusion body myositis. So summarize, myositis-specific antibodies include for dermatomyositis, MI2, MDA5, TF1, 1 gamma, NXP2, SAE1, and NXP2. Anti-M12, classical DM, heliotrope, Schall sign, anti-MDA5, amyopathic DM, and ILD, and ulcers, anti-TMF12, adult dermatomyositis, NXP2 associated gastrointestinal malignancy, and finally SSE, one more 5th autoantibody seen in malignancy, interstitial lung diseases, and amyopathic dermatomyositis. So all these DM specific antibodies indicate subtype and indicate about the prognosis. Anti-myositis specific still DM if the patients have got Gauthron's papule. Please make a note of it. If they have Gauthron papules with clinicopathological correlation, but still MSA is positive, still think of dermatomyositis. So one final simple tool, dermatoscopy, or for Raynaud's phenomena evaluation. Normally 8 to 10 loops are present with hairpins. SSC pattern, we see giant capillaries measuring more than 50 micrometer, and there will be avascularity, early dilated, late neoangiogenesis and sclerosis. In dermatomyositis, Nailfold capillary is less specific. Scleroderma pattern is the best. Always look for Raynaud's phenomena if there are Nailfold capillaroscopy is not available. So these are the important summary. dsDNA, histone, Smith antibody, think of SLE. Law SSB, Rho SSB, think of congenital heart block. Q is also seen in PM and SSC overlap. C1Q SLE, Rho and Law in Sjogren's syndrome. Centromere, RNA polymorphism, RNA polymerase 3, think of diffuse systemic, and also U3 RNP. Then we have even 2 RNP in diffuse systemic, and in rheumatoid we have RA factor and anti-CCP, and in MCTD we have RNP, UN RNP, Smith RNP, think of MCTD overlap. And Joe, EJ, they're all seen in ASS overlap. In dermatomyositis, I mentioned about MI2, MDA, SAE, TF1, NXP2. They're all seen in dermatospecific antibodies. And Q is also seen in overlap antibodies, overlap syndrome. So SRP, as I mentioned, dermatomyositis, and statin-associated necrotizing myositis is seen in statins. And as I mentioned, C1A, it is seen in inclusion body myositis. Thank you very much for patient hearing.
And so Sir Isos Pharma extend our gratitude to the speaker, sir, has given lucid presentation and he expressed his experience to our benefit of the PGs. And today attendance is almost reached 60. So across India, majorly from predominantly South India. And also we extend our gratitude to the course director, Dr. Ketan sir, who was conducting wonderful program for the past 3 years consistently from renowned speakers. So the program is Isos Pharma is committed for the continuous CMEs and programs. So the program will continue for the next month. The topic and everything will be around shortly. The recorded version is available with our Research Pharma field force. Kindly contact them to get the videos. Thank you so much. Have a great day to all.
Again, sorry for the delay. It was inevitable.
Sir.
I
Sir,
apologize
yes.
again.
Sir, it's okay, sir.
Thank you.
Thank you.
Namaste.
Thank you. Thank you. Thank you, sir. Have a great day, sir.